Thank you very much, dignitaries on the dais, Dr. Jenna. Thank you for inviting me to give this talk today. Actually, I think my talk is superfluous after what Professor Adame has already told us. Everybody knows what needs to be done. Somebody has to do it. So my disclosure is that I have no right to give this talk because actually I am not working in sickle cell disease currently, and therefore I really have no right to give this talk. We were one of the largest stem cell transplant centers for thalassemia in India at CMC Vellore. And at that time I realized we are only tackling one end of the problem. And therefore this country needs to have a proper prevention program. So I put this together in 2008. And I'm going to tell you something about this program because there are lessons which we can learn from that. At that time, India's population was 1 billion, estimate of carrier frequency for beta thalassemia 3.3, and about 30 million people with the carrier status. And an estimate that 10,000 children are born each year with transfusion-dependent thalassemia major. It costs 200,000 rupees a year to transfuse and chelate properly a child with thalassemia. Those days, a transplant at Vellore was 600,000 rupees. Today, it will be about 12 lakh rupees or 1.2 million rupees. Transfusion chelation has its problems, and we all know what these problems are. In thalassemia, more so than in sickle disease. Probably most of our children with thalassemia are not being adequately treated or chelated. Now, what is the economics? If you say 10,000 children and 200,000 rupees, that's $3,000 per child per year, the annual cost of looking after these children, if they all survived, would be $1,500 million. That would be the cost. So if only 1% survive, it would be $15 million. Therefore, a national program with an investment of that amount of money would more than reap enough dividends if we prevented the birth of 10% of children with thalassemia. So that's the economics, and I think we don't need to convince anybody about that. Now, having a program doesn't mean that it works. India had a national nutritional anemia program for 60 years, funded by UNICEF. I was one of those who was asked by the ICMR to evaluate the program in Tamil Nadu state. We went from village to village, actually checked the beneficiaries, and to our dismay, we found that 10% of the target population was the only people who received the iron which was provided free of cost. So in fact, at the level of the public health records, the program was fantastic, 90%. But at the field, it was functioning at 10%. So having a program doesn't necessarily mean you're going to impact a disease. Now, for thalassemia, these would be the government agencies which we need, all NGOs, and we need an implementing agency. And these are the people we need at the Central Program Control Facility. And the first thing we need is data. As I was listening through all the sickle cell talks, I realized most of us are talking without adequate data. We don't have a cohort of children who have been followed from birth for at least 10 years even. And unless we have that, we can't really talk. So data is the most critical thing required, and that was even for thalassemia. Who all are working? What are the resources available? What is a map of thalassemia services in our country? And I actually decided at that time the best way is to go to industry. So I went to Frost & Sullivan, who are management consultants, and they gave me a program where they said, we will map the demography of thalassemia and the services available for thalassemia in this country. I believe we have to use these sort of resources to get something done, and this was the proposal they gave me. The second thing we need is an information program. And who should we go to? We should go to the professionals. Ogilvy Health World is the largest advertising agency in this country. And if the Pulse Polio program in India is working, it's partly because of the program developed by Ogilvy. You go to their place of work and you find these hundreds of young people who are just enthusiastic, developing promotional and advertising material. And they are the ones we must use. So Ogilvy actually gave me a 360 education program which was appropriate for thalassemia. And this is Amitabh Bachchan. I went to the sets where he was shooting and I asked him, will you do a 30-second promotion program for me? No problem, doc. Tell me just when you want it shot, right? So this is a happy marriage scene. Scene 1, scene 2, baby born, 10 months later, again heavy happiness. 6 months later, the baby is pale, weak, and Amitabh Bachchan will point to you and say, this could happen to you. Get yourself tested. 30-second clips shown on national television 3 times a week for 2 years. Enough people will come and get tested, and they have to pay for the testing. So this was the program as I envisaged it for thalassemia. 100 rupees, that is $2, is all that it will cost to get a HPLC done to screen your A2 level accurately to diagnose thalassemia. Sample, the methods of collection, I tracked in iron deficiency along with this because that's a major national problem, and we could counsel and provide treatment for people. And I wanted to do this with the best technology available. I did a project among sickle cell patients run by medical students in Karnataka. 1 microliter of blood dropped into an Eppendorf tube, sent by post, absolutely stable. You can make an accurate HPLC diagnosis. Cost would be 100 rupees or $3. That's beta thalassemia. And these are the mutations in our population. And at Vellore, we now do a reverse dot blot at a cost of 1,800 rupees. That's about $20. These are the mutations in our population, and this was the budget that I proposed to the Government of India, but it never saw the light of day, and the program has still not been funded, not to say that people are not working with thalassemia. Now, coming to a national program for sickle cell disease, based on what I've told you, sickle is not beta thalassemia. The population is different. The approach to prevention has, therefore, to be different. And that's the sort of map which all of you see. And I looked at the 2011 census, which said there are 104 million tribal population. Now, if we assume that that population has doubled, there's 200 million, then the target population that we have who are carriers would probably be about 20 million. Much smaller scale than thalassemia. Now, what would be the management? Professor Odami has told you 3 things which make a difference: penicillin prophylaxis, pneumococcal vaccine, and hydroxyurea. 3 things, 3 low-cost interventions which make a difference, right? Now, what are we going to do? All of you know education, screening of the tribal population, confirmation of diagnosis, implementation of the 3 basic strategies which are low cost, providing treatment for complications, and antenatal diagnosis. Now, one of my classmates, Dr. Nandakumar Menon, is working in Gurulur. I had an opportunity to go and visit him. And I think he stressed very, very importantly that these programs must be owned by the tribal population themselves. It must not be somebody from outside telling them you do this. They must own it. They must administer it. They must be educated to run it. Otherwise, it's just not going to work, right? So that's, I think, a crucial lesson which I learned from visiting his center. Now, in India, these are the government agencies which will have to be involved, and there's a Ministry of Tribal Welfare, so we need to include the Ministry of Tribal Welfare, apart from the Ministry of Health, the ICMR, because they've been doing pioneering work in the area of sickle cell disease. All NGOs working and a coordinating cell to be set up. A central program facility is necessary, whether it's in Delhi or somewhere else is the question. We must collect a map. What facilities, who's doing what is the data available, collate it and ask Frost and Sullivan to do this, pay them whatever it costs, right? And this map would be what would guide us, because in many places things are happening. You don't need to intervene. You just need to support and see that it goes on. Now, screening would be the major tool, and I believe in India the solubility test has been used most often. Cost 1 rupee, 2 rupees. So we have a screening test which is extremely low cost. Problem is that it's not easy to differentiate homozygous from a heterozygous with solubility done by the tube test. So this is a paper which was published in PLOS 2016. That's just last year, this paper, and it was an amazing paper. As I was preparing for this talk, I saw this. Same reagents as for the solubility test. Put a drop onto a piece of paper. 10 minutes later, if you are homozygous, then you will have a single central dot like so. You can't see this properly in the projection, but you'll have a nice circle of normal hemoglobin around the central dot. Cost virtually nothing. And you can automate it, right? As for everything, you can put in a little scanner, you can get a handheld scanner with a laptop, you can take it to any village you want to, and that converts the dot into a 3D representation, which can be read by the scanner and collated. And look at this amazing data, right? Sensitivity 100%, specificity 97%. With the automated NPV, it's 100%. You can't ask for anything better. And you can differentiate between the two. So for India, it should be solubility done preferably with a paper, cost 2 rupees, 3 rupees. Confirmation of diagnosis for this, whether we are going to use electrophoresis or whether we're going to use HPLC is the question. My personal preference is that you have a central center where 1 microliter of blood in an Eppendorf tube is sent off to the central center. Dr. Patra is doing it in Odisha. And you get a reliable estimation. Total cost 100 rupees. That's about $3, $4, right? And you could confirm between trait and homozygous. Now, this is a question. Professor Odame addressed this. Does India need newborn screening? Now, newborn screening by current American standards requires 2 independent methodologies to confirm. And you would need isoelectric focusing plus HPLC. I was talking to the PerkinElmer people and they say it's not expensive. But the equipment is, and setting it up and getting reliable isoelectric focusing is not going to be easy, right? I personally feel that this is a graph showing the rate of fall in hemoglobin F in people with sickle cell anemia, and the open squares represent normal. And if you look here, at 10 months, you have a significant amount of fetal hemoglobin. Now, when do you need to diagnose sickle in order to intervene? If you had pneumococcal vaccine, then you need it only at 2 months. You don't need it at birth. You don't need isoelectric focusing. So if we make a diagnosis at 2 months, if the government of India gives us the money, we have pneumococcal vaccine, that's all we need to do. Pick up the diagnosis at 2 months, right? And this is probably why the recommendation to start hydroxyurea is 9 months. Why 9 months? Because by then, even in an SSA, the fetal hemoglobin levels have started to come down. Now, pneumococcal vaccination, this is a paper which I'd recommend in Indian Journal of Community Medicine. These are the serotypes that are prevalent in our population, and these are the serotypes which are covered in the 7 to 13 polysaccharide protein conjugate vaccines. And Pfizer's global market was $4.5 billion for pneumococcal vaccination. GSK a little bit cheaper. So it will cost approximately 12,000 rupees to give 4 doses of pneumococcal protein conjugate vaccine to our population. And that is something that the ministry might balk to give us the money. The hope for us is that India is entering. Professor Odame said how HIV drugs are available in sub-Saharan Africa. And India can be proud that we are the reason. Drugs produced in India at low cost were sent all over the world, and that was the reason why it became available. 3 companies are developing a protein conjugate vaccine. There's a startup company called Tergene Biotech in Hyderabad, and Tergene Biotech by next year will have a 15-valent protein conjugate vaccine tested. And I bet you the cost will be 1/10 the cost of Pfizer's or Sanofi's product. So we have some hope around the corner. This is the schedule for administration, 3 doses. Now, penicillin prophylaxis is the second question. When should it be given? And the current recommendation is to start at 2 months of age. For us, it is something we have to think about. But you know, we have new cohort studied from birth to 5 years even to say, yes, this is the frequency of pneumococcal sepsis. This is the death rate. This is how intervention is going to change. Hydroxyurea, I believe it transforms the life of children with sickle cell disease, and the current recommendation from the NHBI is to start at 9 months, which means even if they have not had a crisis, start at 9 months. I somehow agree with these recommendations, and this is what we should do, and I believe it really transforms the life of children. Now, we need centers where people know how to manage sickle cell complications. And that's critical. A baby comes in with sequestration, you don't intervene properly, the baby will be dead. So we need centers where people can recognize and tackle complications of sickle cell disease. So this is my last but one slide, suggesting that we need a central coordinating agency. We need tertiary referral centers in 4 parts of our country. These should be able to do molecular diagnosis, antenatal diagnosis, management of complications, hematopoietic stem cell transplantation, necessary research. And that's the most important of the lot, is research on the biology of sickle cell disease in our population. We need state-level coordinating agencies. We need tertiary care medical college to do the complicated cases. A district hospital where from the tribal area the baby can be referred to, and the primary health center would do the screening, the education, the prophylaxis, the primary management, and referral. So this would be the model which is applicable, can be done. You know, when I came to Chhattisgarh, to Raipur, and saw what the people in Raipur, particularly Dr. Patra, are doing, I was humbled. Here is a program which is actually working. People screened, properly documented, data available. Now, I'm not saying this is not happening elsewhere, but if it can be done here, and I visited Naya Raipur, which is the new city that is coming up, beautiful, wouldn't mind living there, 6-lane highways open, and they have been given 25 acres of land and a 100 crore budget. They can be the reference center for India. So the way forward for us is to expand on great programs which are working in the country, fund and strengthen them, and use them as models for expansion. Patra and the group in Chhattisgarh, my own classmate, Dr. Nandakumar Menon in Gurlur, and many, many others who are working. Thank you very much.